Yeah. Thank you very much again for inviting me to this conference. Continuing talking about subfertility. Yeah, but it's not male fertility. It will be more about female fertility and endometriosis. Basically, as Dallas said, I'm a consultant gynecologist specialist in advanced gynecological endoscopy surgery and endometriosis. I work in London Northwest Endometriosis Center, which is, of course, it is an important contributing factor to a good number of women population with subfertility, as you will see. And endometriosis, this hospital, because my hospital is across 3 different sites, we cover very big borough, very big population, like over 500,000 woman population, because we nearly cover the whole of Northwest London, up from Northwest from Harrow, Northwick Park Hospital, going down to Ealing and up to Wembley Stadium with Central Middlesex Hospital. So we cover across 3 different sites. That's why we have got a very population, and of course high number of women with endometriosis, which we will discuss how we can approach this. Basically, we have to agree about endometriosis is a bit challenging condition. Why it's challenging condition? Because yeah, we have been trying to find why it happens for a long time, and we don't know why yet. We don't know exactly the reason why it happens. Why? We know that it's most likely due to high estrogen level in most women, or high estrogenic level. Some say family history, but why someone to have high estrogen don't have endometriosis? Why family history is not applied in every woman? This is not only the problem. It's not only the problem is not only in the cause or the reason for endometriosis. It's the classification as well. How we can classify endometriosis is not like other classification, like of, for example, in preeclampsia or fertility. No, it's hard to classify endometriosis because the whole aim of any classification is to be reflected on the symptoms of the patient. Not only this, to be reflected on the proposed treatment and the future plans. Because no point I say, for example, this woman has got stage 4 endometriosis, but she does not need treatment. I mean, it doesn't make much sense. You know what I mean? How is she stage 4 and doesn't need treatment? Yeah, but this in real life it happens. I've seen women with stage 3 and 4 endometriosis who don't need treatment because they are asymptomatic. That's why endometriosis is a bit tricky, and it's very specialized topic. The endometriosis, yeah, we said that there's a problem in to find the reason and the cause of endometriosis. We don't know yet, and how to classify endometriosis. Not only this, how as well we can diagnose endometriosis. There's no consensus agreement about how we can diagnose it. If you look at the European Society for Reproductive Medicine, American Society of Reproductive Medicine guidelines for the last, no, sorry, go back, please. Yeah, for the last 20 or 30 years, you'll find that the way of diagnosing endometriosis has been changed every time, depending upon all the evidence, how we gather evidence, how we collect more strong evidence, so we find different way of diagnosing it. And there is no a single way of diagnosing it. And even we can say if you do this test, it is endometriosis. No, unfortunately, we can't. Not like, for example, diabetes. When they're high blood sugar, she's diabetic. And these are the levels for diagnosing diabetes. Or not like preeclampsia. If a woman had high blood pressure and proteins urine, or had some blood, okay, she is preeclampsia. No, there's no single test or investigation which can say this woman has got endometriosis and this woman hasn't got endometriosis, unfortunately. The problem is bigger than this. It's not only about yeah, if it is only about to find the reason and diagnose and classification and diagnosis will be fine. The problem is that we are still finding new ways of treatment of endometriosis, because endometriosis treatment varies. I know most of us know most of the common things which will get through it in a minute, but what is the best treatment? What is the perfect treatment? What's the ideal treatment for endometriosis? And why do some women respond to These medications, they have both endometriosis, so both might have the same stage classification, or if you follow up enzyme classification. I'm not sure how many endometriosis specialists are with us today in the conference, but I'm trying to make a subject as easy as much as I can. So basically, why, for example, woman has got same stage, same symptom of endometriosis, why some women do respond to certain kind of medication, other women do not respond to the same medication, and why someone do not respond at all to this kind of medication. We try them different medication, and we don't know why they don't respond, and why does endometriosis come back after we treat it. Why does it come back? So it is not a condition which you get antibiotic and get rid of it and it's done. No, it's a long-term condition which the woman do have it throughout her whole childbearing period, and even after she goes in menopause as well, because as you all know, ovary is not the only source of estrogen in the woman body. There are other sources of adrenal fat, other sources. That's why we have seen menopausal woman with endometriosis who needs a treatment, and that's why it makes it more challenging conditions. There have been a lot of research and studies and publication about it, but we are still trying to find our feet and the best way. And anyone, especially in endometriosis, find how this woman suffer, how does it affect the quality of life a lot, how does it impairs their ordinary physical activity, it impairs their sexual life, it impairs some of them are just crippled in bed for the days during the period. It's a very big, it's a very big issue. As I said, endometriosis is the most complex gynecologic condition, and it does affect women of childbearing age potential, but women with menopause do have endometriosis as well, and some of them become symptomatic and do need certain kind of treatment. But of course, as I'll say later, we cannot apply the woman who is with the functioning ovaries treatment, which apply to women is functioning ovaries. To women who are past the age of menopause, we cannot apply same treatment because I will see later that treatment is mostly targeting ovarian activity. But what about a woman who's menopause of no active ovaries? What will target? No point. You know what I mean? We'll come to this later. And as I said, the prevalence is about 2 to 10% of the female population worldwide, and up to 50% of the infertile women were found to have a certain degree of endometriosis, whether stage 1, stage 2, stage 3, stage 4, or if you are going to the American classification or NZ classification, whatever. And it's a big problem. It's a big problem for women in women in general, and women or fertile women in more particular. Basically, endometriosis, the main problem with endometriosis is the pain, and the pain which stops the woman from doing any ordinary activity. This pain, mostly during the period, can be before the period, can be during having sexual life, which some women cannot have any sexual. Unfortunately, it stops the sexual life because they find it so painful. They cannot carry on with this. Pain on opening the bowel, especially during the period. A pain on passing urine. This pain does affect the quality of life, and all depends upon the location, the extent, the degrees, the size of the lesions, and where it is in the body, the endometriosis, where it is on the bowel, in the bladder. Is it extra pelvic? Is it abdominal? All this does affect the quality of woman life, which of course get reflected on her family, on her work, on her social life, on her friends. It causes a significant impairment, definitely, and that's why we have to address it. Next, please. Yeah, but what are as I said in my first slide, we don't know exact reason because if we know the exact reason, we'll treat it. We know that pneumonia is caused by bacterial infection. We give antibiotics, and it will treat it. And it will treat the bacterial infection of pneumonia. Sorry.
Dr. Veena, could I ask that you mute yourself, please? I apologize, Mr. Hosni. Please continue.
Okay. So basically, as I said, there is no reason, basically, if a woman have got hypertension, we'll give her antihypertensive medication to control her blood pressure down. But we don't know the reason of endometriosis. We only know risk factors. Why do women are more likely or most probably develop endometriosis? One woman do not less likely to develop endometriosis. This is basically a table I got it from the New England Journal of Medicine. It was published in 2020, and they talk about the probable risk factor and the possible risk factor. Probable risk factor. What's the difference in probable and possible? Probable means that woman do have it at one point of time, and she's most likely will get endometriosis at one point in her life. Possible risk factor, yeah, it might be a contributing factor, but there is no guarantee that this woman will, or there is no, we can say that she will get endometriosis in her life 100%. We cannot sure. So probable is most likely she will get it if she has been exposed to any of these factors. And possible is less likely, but might be a contributing factor. So what are the probable risk factors? In childhood, if the girls or the woman has a low weight at birth, if they were small for gestational age, Mullerian anomalies, you know that Mullerian anomalies, the Mullerian duct and Mullerian system is a precursor of the uterus, the tube, the cervix, and upper third of the vagina. If the woman who develops Mullerian anomalies, they find that more likely to develop endometriosis. What about at the adolescent period? Adolescent period, girls who start to menstruate at early age, at the age of 8, 9, 10. These girls are more likely to get endometriosis later in life. As I said, it's all risk factors. They are not a cause. I mean, we can say 100% will get endometriosis. No, it's all risk factors. They are most likely to get it, but there's no most likely up to 90% or even more. But you can't say for definite it is the reason for endometriosis. Girls in the adolescent period at the puberty who had a low body mass index, and we all know that body mass index basically is the relation of the weight and the height of the woman who has low body mass index, like less than 19, 18, 17. These are women are more likely to develop endometriosis later in life. What about when they become, when they leave the teenage period and they become in the adulthood period? Girls and women who experience short menstrual cycles are more likely if they have got increased amount and duration of their menstruation. Also has low BMI. They have been low BMI at the adolescent period and then adulthood, or woman who has never been pregnant before. Because as I said, a few minutes ago, that we know that is related to high estrogen level, but we don't know why some women has high estrogen develop endometriosis, other do not. And that's why women who nulliparous, who never have been pregnant, basically we know that the ovary stop functioning at the time of pregnancy and after menopause. Ovary, because during pregnancy, the function is taken over by the placenta, and is the progesterone, which is the dominant hormone at the time of pregnancy. Basically, women who are nulliparous have never had a rest period of high estrogen. This high estrogen has been there all their life, not having, because rather than they having a period of when the estrogen goes down and the progesterone go up during pregnancy or after delivery. So basically, they are persistently or constantly exposed to high estrogen level in their body, and that makes them more prone to develop endometriosis. So what are the possible risk factors? Possible risk factor, as I said, is there can be contributing factor, but they are less likely. I mean, less contributing factor endometriosis, but we cannot say they are a strong risk factor as a probable risk factor. Women who had, girls who had diacylstilbestrol or their mother in childhood. This is a tough issue which we stopped using it long ago because it has downsides. Girls who like to be exposed to a sun, to like to have some baths and sun tans for a long time, especially if they are sensitive to the sun. Not everyone get to have sunbath Santa for a long time, especially it depends because everyone's sensitivity, we know that everyone's sensitivity is different to the sun and to the pain. Girls who are more sensitive to the sun and are exposed a long time for sun, it can be a contributing factor. If we compare the low waist and hip ratio, is more or less likely same contributing factor. As I said before as well, during pregnancy and after delivery, estrogen level is low and progesterone level or prolactin level is high. So women basically who do not breastfeed or have short or breastfeed for a short period, they are more persistently exposed to high estrogen level, which can be a precursor or one of the hormonal predisposing factor for endometriosis. Because as we know, endometriosis is a hormone-dependent condition. It's not life-threatening, it's not precancerous or cancerous, but it does affect the quality of life. It's hormone-dependent, basically. And the hormone basically related to high estrogen level. If they have like these are all theories, women who or girls who takes eat red meat and transaturated fat a lot, but as I said, these are all theories and they are not strong theories, and any endocrine issues. Yeah, so this is a table which show the risk factors, but as you can see, there is no reason because many women who has got this factor and they don't develop endometriosis, and we don't know why did not develop endometriosis. Women, why these girls nulliparous women never develop endometriosis. We don't know why. Next, please. Next. Yeah. So this is a problem with endometriosis, and as I said, it's a hormone-dependent condition because with high estrogen, if we try to get our target usually is to suppress ovarian activity, so that estrogen level in the body goes down, so that endometriosis lesions can shrink and have less effect and become less painful. And then we said, okay, okay, if this is a problem, okay, that's fine. Let's do them. If women who will come with pain and suspect endometriosis, let's give them hormonal treatment. Like, for example, progesterone pills. Give them Marina. You know, Marina is like progesterone medicated coil. Give them combined pills. Give them any treatment which help to suppress ovarian activity so that the endogenous estrogen production goes down and women can have better life. But then the paper came up from in North Carolina, say that not all endometriosis respond to hormonal treatment. It says, and the response to hormone treatment cannot predict the presence or absence of endometriosis. So we see all women who give them progesterone treatment or contraception, and they respond really well. And they said, okay, let's use it as a diagnostic test rather than therapeutic test. But they found that women do not respond, but they have endometriosis. They said this most likely deep infiltrating endometriosis. Deep infiltrating means it's not superficial. I mean, it actively involves the bowel or the bladder or the peritoneum or the deeper tissues. They say that this woman, these lesions do not respond to hormonal treatment. That's why women do have treatment, but they do not respond. Not even this. Okay, if the woman, does not respond, does respond, that means they have endometriosis. He said not necessarily, because there might be other contributing factor to pain, as I will say later. So to use hormonal therapy as a way to diagnose endometriosis is not useful. Is not useful test, because if she responds, does not mean that she had it. If she does respond, does not mean that she does not have endometriosis. Okay, next, please. Yeah. And then we said, okay, let's do laparoscopy then for everyone who come with pain. Laparoscopy, basically, we'll see endometriosis if the endometriosis, superficial endometriosis, ovarian, we'll see it by laparoscopy. First, we have not to forget that laparoscopy is not risk-free procedure. It has got, of course, complication of anesthesia, bleeding, infection, damage. It's not the simplest procedure. No, it has a lot of risk factor and have came across numerous complications with laparoscopy. So we cannot, every woman has got pain, we cannot offer laparoscopy. No, the risk, it depends upon the balance of the risk and the benefit. Because in many of them, the risk will outweigh the benefit. The risk of laparoscopy will outweigh the benefit. Not only this, not only about the risk of laparoscopy. If you look at the recent ESHRI guidelines, the European Society of Human Reproduction and Endocrinology, they said that diagnostic laparoscopy should no longer be the diagnostic gold standard. Because we used to say that if you want to diagnose endometriosis, do laparoscopy. It's not only about the risk. They said no. They said it should not be the gold standard. Should not. We can diagnose women with endometriosis without using a laparoscopy. We said we take history, we do clinical examination, and we do imaging. We do scan. We do MRI pelvis. It can help us to diagnose endometriosis. Okay, but what about if the negative imaging and the clinical examination is negative? Not only this, they said if the imaging negative and the clinical examination negative, and you give her empirical treatment as unsuccessful or is inappropriate, basically inappropriate means that it is contraindicated. She cannot have hormone treatment for a certain other, or the girl is quite young, or she wants to get pregnant. You can't offer a woman who wants to get pregnant conception. Doesn't make sense. Yeah, then we can go for laparoscopy diagnose it, but laparoscopy is not the safest procedure. In the contrary, has got a lot of complication, and is not will not and should not be used as a gold standard for diagnosis of endometriosis. Not only this, you might say, okay, women agree for the to go for laparoscopy and she is accepting the risks because she does want to know what does she have, what's the problem, what's make her life so hard. Yeah, but we have to agree that negative laparoscopy does not rule out endometriosis. So basically, if you went in with laparoscopy and we didn't find endometriosis, that does not mean that women do not have it, because it might be deep infiltrating the tissues. Because with laparoscopy, we only see what's superficial peritoneal lesions. We don't see what's under the peritoneum. We don't see what's inside the bladder wall or the bowel wall or the uterus. That's why negative laparoscopy does not mean that women do not have it. No. It means we have to look at it further. That's why the ESHRI guideline came and say we should not be gold standard for all this reason. For risk factors, it can have a lot of risks and not necessarily diagnose every endometriosis as well. And then the recent report came from France saying that okay, hormone treatment cannot diagnose endometriosis, laparoscopy not necessarily. They try to look at like RNA, serum RNA microRNA analysis from the blood. They start to look at blood test and serum test to diagnose endometriosis. It's a very interesting paper and it comes from France. But needs time. It only came out in the last few years. It needs time to use it worldwide or nationwide. To use it for to diagnose endometriosis. It gives it's very promising. It's giving very good results, but it has to be applied to a larger number of population, larger number of groups to use it as a diagnostic test or diagnostic tool to diagnose women with endometriosis and rule out women who are suffering with chronic pelvic pain but do not have endometriosis. Next, please. Okay, this is a problem with we talk about the reason, and we talked about how to diagnose endometriosis. You see, in every step of the endometriosis, as we talk through it, we find a problem. We are facing a problem and it's challenging. We are facing a problem, we don't know the reason. So how can we treat it? If it's a problem, how we can diagnose it? If laparoscopy and hormone treatment is not helping. So it's very interesting for me, at least, but it's very challenging and it's not, I wouldn't say ambiguous, but I would say it still needs a lot of work, not lot of work to know there are a lot of things we still do not know about endometriosis, despite that we are in 21st century. This I'll talk about the classification of endometriosis. I'll show you the two most common or most used classification worldwide. There are a lot of other classifications, but these are the most common used. Of course, the revised American Society Reproductive Medicine classification is quite old. There is over 20 or 20 years or more, because this is a revised one. There was been original one, which is different from this one. Because basically it says by doing laparoscopy, look and start to give numbers about the lesions. How big is the lesion? What is the site of the lesion? Start to say, was it in the right ovary? Was the left ovary? Is superficial? Is it deep? In the right tube, left tube, do a pouch, and they add up. They add up the numbers, and they say, okay, from 0 to 5 is stage 0, from 6 to 10 is stage 1, and go on and go forth. Yeah. It's quite useful, of course, but does not guide us for treatment. Because sometimes we find the stages not correlated symptoms. Patient not symptomatic or has got mild symptoms, and she has got stage 4 or stage 3. Or the other way around. Woman has got stage 0 and stage 1, and she is struggling. She's suffering in all her aspects of life. And then a Dutch guy came with this classification. He said this more like is more expressive or more useful to diagnose the degree of severity of endometriosis. And he classified into peritoneum, ovary, tube, endometriosis, and he started classified depending on the size of the lesion, on the site of the lesion, and the location, and all the things. Of course, the whole point of this classification, of course, to guide clinician to diagnose and treat, but also for easier communication with each other. Basically, because if I speak to one of my colleagues and I told him this patient is NZN P1, O2, T3, for example, he should understand rather than trying to describe, because this my colleague was not with me in the surgery. But if I try to say it in this way, he will understand the situation better. Okay, it's the same with the other with the American Fertility Society classification. This for the conference, when I say stage 3, everyone understands what stage 3 endometriosis or stage 2 endometriosis, even if not doesn't reflect the exact severity or the treatment proposed or the future plan. It's basically like pregnancy, for example. Pregnancy, we say we calculated from the first day of the last menstrual period, but the woman did not get pregnant in the first day of the last menstrual period. She got pregnant 10 days or 14 days after, 15 days after, but just for universal agreement, for consensus agreement, so that everyone understand what I'm speaking about, rather than try to prescribe. And she has got this in Douglas pouch, and she got this in the right ovary, has got this. It's no, it's not working. It's too long. It's a lot of hassle. If I say she had stage 3 endometriosis, she has P2, O1, T3, and C1, like this, it will be more clear for everyone at the conference, for all my colleagues, and for any, especially if the patient, because she might have moved her care to a different trust or move her care to a different doctor, he must be aware of what situation in a more scientific term rather than in just a jargon descriptive language. Next, please. Okay, and now we came to I wouldn't say the most tricky part of endometriosis, but one of the trickiest parts of endometriosis. How we can manage endometriosis? How we can treat it? We don't know how to. We don't know the reason. We don't know how to classify it, and we don't know. We don't know much about, but we have to treat it. Basically, to treat endometriosis, we have to agree about something. We don't treat endometriosis in general. We don't treat diseases. We treat women or men, of course. But I'm talking about women because this I'm gynecologists. We don't treat disease. We don't treat cardiac problem. We treat the woman. We don't treat fibroids. We treat the woman. What does it mean? That if a woman come with has got fibroid 2-3 centimeter, for example, she's asymptomatic, I will not offer her any treatment as long as not causing any problem and she's living well with it. Why do I offer treatment? Because I'm, as I said, not treating fibroid. I treating the woman. I want to get her better quality of life. And if she's trying to get pregnant, I want to help her to get pregnant. But we're not treating this in general. Not in general. We don't treat women. Anyway, woman who comes with endometriosis, we have to first find out what's her main problem. Is her main problem is pain? What is her pain? Dyspareunia, dyschezia, dysuria, dysmenorrhea. Is it pain or is it suffered? She wants to get pregnant, or is it both? Because what applies here does not apply here, and we'll see in a minute. Because basically, with some fertility, woman wants to get pregnant. You can't offer her treatment to suppress her endogenous estrogen level, which basically means suppress her ovarian activity. Doesn't make sense. She wants to get pregnant. How you can say, okay, let's offer her conception? I mean, it doesn't make much sense. So we have to look her at a different aspect, with different perspective. Next, please. So basically, we'll start with women who have or came with pain. Pain is their main symptom. Next, please. Yeah, this is basically a nice guideline. Nice what's nice, basically, just because I'm not quite sure if everyone aware of the practice in the United Kingdom. Basically, NICE is National Institute for Health and Clinical Excellence. That's exact what NICE stands for. The National Institute for Health and Clinical Excellence. What does this do in the United Kingdom? Basically, it gives us not only for gynae, for all medical specialties, whether orthopedic surgery, whatever, give us guidelines, give us protocols, or so that we can standardize the treatment across different trusts of the country, so that we all have the same approach. Because basically, NICE, what does NICE say? NICE look at the evidence-based medicine. Look at, for example, endometriosis. It looks at the strongest based evidence for treatment endometriosis, and she gathers the experts of endometriosis, and they write this guideline, so that, because this guideline is not only for specialists, guideline for primary care, for GPs. GPs means the family doctor, general practitioner, family doctor, to see what can they do. A guideline for doctor in secondary care, even for us as well, because nobody can read every paper every paper about endometriosis. So we always have to keep our skills and knowledge up to date. But nice gather all the evidence and knowledge and try to simplify it in one guideline. That applies, of course, to the United Kingdom, and I gather every country has got a more or less similar governing body like NICE, just to make things easier, because NICE only came up like in the last 20-30 years, just to make sure that women are receiving the best treatment. Not only this, to ensure patient safety, which is the most important thing before we offering any treatment. So patient safety comes first, and then we should offer her the best evidence-based medical or surgical treatment that will improve her quality of life. That's what does NICE do in the UK, whether in Scotland, Wales, Northern Ireland, or here. You can log it. If you log to NICE guideline, you can access. If you log to NICE website, you can easily access this NICE guideline. It's free for any overseas candidates who would like to look at it, and you can access it without any subscription. It will give you a lot of advice and guidance. Next, please. Okay, so let's go back. So as I said, endometriosis has got two main problems. It's pain, with different kind of pain, as I mentioned before, or infertility or difficult to get pregnant, makes it challenging to get pregnant. Let's focus first about women who came to me. Of course, they passed through a family doctor and GP, and they were referred after family doctor ran out of options to treat this woman or girl. And they refer to me and I have to treat their pain. There was say when I was a medical student used to say that a good gynecologist should be endometriotic minded and good obstetrician should be ectopic minded. That's what during my medical school usually we were told that we have to, as a good gynecologist, you had always to think about endometriosis, and a good obstetrician you have always to think about ectopic. Otherwise, a lot of cases will be missed because they are not the easiest conditions to diagnose and manage and treat. Anyway, one who present me with endometriosis associated pain, I gather should have been offered. We can offer the have been offered painkillers at their GP practice or at their family doctor. But yeah, painkiller like what? Like non-steroidal. Non-steroidal, because they said there are some theories say that the other reason why endometriosis contributes to such pelvic pain and this all kind of pain is that high endogenous prostaglandins. So if we tackle them with antiprostaglandins, it should help with their pain. It's not treating the condition, we are treating the pain, as I said, because we are treating women, we are not treating the endometriosis, we are treating a woman. The whole point is to get her better quality of life. If she's got better quality of life, our treatment is done, our aim is achieved. We don't need to do any more. It doesn't matter has got endometriosis or not, as I said, because it's not a precancerous or cancerous. So we can, she's happy, we are happy. That's the whole point. But of course, downside of non-steroidal anti-inflammatory drug is that it have got, of course, renal effects, of course, and that's why women who has got renal problems do not have non-steroidal. I think there are some theories that it does inhibit ovulation as well. Of course, which will not be good if women try and get pregnant. We can offer them combined hormonal contraceptives, of course, whether it's combined contraceptive pills, patches, vaginal ring. Yeah, these are different ways. It doesn't matter. Different way of contraception, pills or patches, because they all work more or less same. But of course, we know that the amount of estrogen and the amount of progesterone and the type of estrogen and progesterone differ from one to another. Basically, we could say, yes, it's trial and error. Yeah, I'll give her whatever she likes. If she should try patches, try patches. If patches does work for her, okay, let's try a different kind of pill, which certain progesterone. I will come to it later. We usually use it for pills we call Dynogest progesterone. I'm not quite sure if you heard about it or not. Basically, it's one of the combined pills which I usually recommend. We can offer them personally contraceptives, whether pills or IOS means the intrauterine system, like the Marina. Marina is not a coil; it's a system. Why it's a system? Because it delivers progesterone, delivers hormone. It's not. It has got non-conceptive benefits. That's why we call it a system. It's a coil, but it delivers hormone, and or of course implant or implanon. So as you can see, it's mainly our main treatment is basically contraceptives, because our aim is to suppress endogenous estrogen, suppress ovarian activity, so that endometriosis lesion, I wouldn't say shrink, but at least they become quiescent, become quietened, become stagnant. GnRH agonists are a different option, but I wouldn't use as a first-line therapy because it has got a lot of downside effects. And we all know about hot flashes, night sweats, menopausal symptoms. Yeah, that's why we usually leave it at a later stage. And that's why we usually offer it. Usually offer it with Adbacter. What's Adbacter? Adbacter therapy basically means, as we said, our main aim as an endometriosis problem is a high estrogen level, so we want to get it down. Yeah, but with GnH with a gonadotrophin hormone agonist, estrogen level becomes very low. Very low. We achieve the target that it comes low to sort out endometriosis, but it's associated with downsides, with all these menopausal symptoms. That's why we offer them what we call low dose hormone replacement therapy. Some might think, okay, say, okay, what's the point then if what's the point of offering GnRH and agonist to lower the endogenous estrogen and at the same time you are offering estrogen? Yes, it's a good question, but basically GnRH agonist will get estrogen down to less than 5 or less than 10. We do not need it less than 5, less than 10 to get it to treat endometriosis. If it's less than 30 or 40, that will be enough, will be fine. That's why with the low dose hormonal replacement therapy, whatever you use it, we usually use tibulone, but you can use any low dose hormonal replacement therapy, not necessarily. It will bring the estrogen level high up to 20 and 30, but not to 80, 90, 100 or 200. You know what I mean? So I deplete estrogen by the agonist, but to avoid the drawbacks or the side effects or menopause symptoms of GnRH agonist, I offer add-back therapy, which include estrogen, of course. A hormonal replacement therapy includes estrogen, of course, but it will bring the estrogen high up to a milder degree, to a certain degree, without abolishing the positive effect of GnRH agonist on the endometriosis. As I said, it will bring it up to 30 or 40 level nanogram, but not picogram, but not to the level that makes endometriosis active. GnRH antagonists are another option as well, especially come recently they start to become more used in the States, and UK start to use it, but they started in the States before. Basically, they are oral tablets like linagolix and rigolix, rilgolix and linagolix, and they are quite useful. We are very apprehensive here in the UK to start using it because we had a bad experience with one of the previous treatment for fibroids and found to have liver downside liver later, a few years after using it for a long time. That's why we start using it, but in a very slow pace, and it will need years to say those are quite effective or not. But the States they start use it before us, quite a few years before us, and the reports coming out from there, it says it's very effective treatment for endometriosis.
Yeah, Mohamed, I just need to ask you to wrap it up as we're running out of time. Thank you.
Sorry?
Could you make it wrap it up for us because we're running out of time?
Okay.
Thank you
And then the
very much.
aromatase inhibitor. Okay, that's fine. Okay, next, please. Next. Yeah. And this surgical treatment. Suppression is temporary, but as I said, there is no definitive cure. There is no radical treatment for endometriosis. And of course, you cannot offer medical treatment if the endometriosis causes some sort of obstruction to the kidneys, if it causes some sort of bowel obstruction, if we find an axial mass which is of doubtful nature. We have to have surgery for these kind of conditions. Next, please. Next. Sorry, no, go back. Yeah. A hysterectomy does not cure the disease because the problem is high endogenous estrogen level and the ovarian activity. So hysterectomy on its own will not cure it. And unfortunately, no prognostic marker occurs to select patients that benefit from surgery. Next, please. Yeah. What about if woman who came with fertility? Ovarian suppression is out of the table. We can't offer them contraception. Aromatase inhibitor can prescribe it only if part of fertility protocol or induction ovulation as a part of fertility treatment. Next, please. Surgery. Of course, surgery is good for, is most likely the most convenient treatment for women with subfertility, guided by the endometriosis fertility index. I'm not quite sure if anybody's aware of it. If you put up get up the endometriosis fertility index, please. Can you get up on the screen? Yeah, this one. Basically here, we check how much endometriosis, the mild dysfunction, and we check the endometriosis, the fallopian tube, on the ovary, on the fimbria, and we add up the score, and we come out with the AFI score, which is quite useful in guiding us for treatment and for prognosis of women's fertility. Next, please. Yeah. And then, okay, so what is the treatment? Basically, we say, okay, what about endometrioma? How can we treat it? We say, okay, it's easy. Endometrioma, we can follow it up. We'll see what it affects the ovary by itself. The treatment affects the ovary by itself. Treatment of endometrioma and cystectomy affects the ovary because it takes out some follicles, it or the discernment effect of ovary. And they say, okay, let's do cystectomy. But then a paper came from Italy say even stripping endometriosis with a laparoscopic surgeon can negatively affect the ovarian follicular reserve. And then the paper comes out, okay, what about after we do treatment endometriosis, what about bowel endometriosis? Or different. We know bowel endometriosis can have shaving, can have dissection, disc excision, can have resection anastomosis. What about the mode of labor and delivery after? These are all questions need to be answered. Next, please. Yeah. Okay. What about colorectal endometriosis? If woman comes with subfertility and has colorectal endometriosis, should we treat the endometriosis first or should we refer her to the subfertility and come back and treat endometriosis? And then they say, no, it can cause bowel obstruction during endometriosis. And then another paper came saying we have to swim again in the stream with surgery worthwhile with deep endometriosis and pregnancy or not. Should we do surgery before IVF or after IVF? And with current risk of bowel obstruction during a pregnancy. And then another paper came out and say, let's speak about it's about the singer, not the song. It's about the surgeon and not the surgical technique. Next, please. So what are the major advances? Advance basically, of course, okay, if cystectomy affects the ovarian reserve and damages the ovarian reserve, what's the solution? Sclerotherapy is a new advancement treatment of endometrioma. Using the endocyanin green fluorescence for delineate uterine vasculature to help us treat endometriosis. Development of 3D laparoscopy give us greater depths and more tactile feedback. Next. Robotic surgery, of course, has got a role in endometriosis. The ultrasound dissector, the cordless free. The use of a knotless tissue control device, the one without a knot, and the digest tablets is a risk have been used new for some time and has been reported good effects. Working together is very good, it will help definitely treat women's endometriosis. And another advance was how to treat rectal endometriosis, say by laparoscopic reserve for submucosal dissection. Basically, rather than doing resection anastomosis, because it has got a very hazardous effect on the woman, resection anastomosis, and affect her quality of life, let's do a partial thickness coil excision instead. This came from Australia and New Zealand. Next, please. Yeah. And finally, okay, what about the effect of surgery? What about, we have to look at the other side of the story and how we treat endometriosis, because not only about surgery and medicine. Next, please. Because the pain of endometriosis is not about the lesion itself. It's characterized by potential sensitization of central nervous system that can result in persistent pain even after the lesion have been excised. So we have to look at alternative ways of managing pain. Next, please. Yeah. So conservative is we need to look for conservative therapy and physiotherapy. At London Northwest Endometriosis Center, look at the physiotherapy as a holistic approach to treatment women with endometriosis. Offers them pain education, manual therapy, pelvic floor exercise, and promotion of healthy bowel and bladder practices. Especially the current guideline lack this physiotherapy guidance. Next, please. And unfortunately, this needs to be evolved, and we start to control. We are starting doing pilot study. Or starting a first randomized control study. Next, please. Yeah. So sorry, go back, please. Yeah. We provide 6 physiotherapy sessions for all women with endometriosis initial consultation at the end of physiotherapy session, and we give them the pelvic pain questionnaire before and at the end of the 6 physiotherapy sessions. Next, please. So in conclusion, basically, a lot of challenges ahead, whether in diagnosis, classification, management, endometriosis. The amount of these doesn't correlate with the frequency and severity of symptoms. Actually, should not perform surgery or prescribe medical treatment in women with incidental finding. Incidental finding means the woman asymptomatic, because as I said, we don't treat endometriosis, we treat women rather than endometriosis itself. Next, please. Yeah, and other approach to endometriosis pain is more important, as I said, like manual physiotherapy. Next. Yeah, thank you so much.